Thank you very much, Grant. Ladies and gentlemen, all protocols observed. Thank you very much for the invite. Thank you very much for the invite. I feel very honored to be here. Like Dr. Mrewanema mentioned, the topic of the presentation is going to be on patient management guidelines or clinical practice guidelines. But I thought before that, maybe let's just have a brief look at what I have termed the timeline of the typical obstetrician here in Zimbabwe, and I'm sure in our neighboring countries as well. So this timeline begins when one is specializing. This is a period full of drama and boundless energy. I'm sure you can picture two registrars discussing on the corridor leading to the labor ward, one saying, you know what, last night I did 10 cesarean sections. And then the other one says, that's why there's still a backlog in the labor ward, you're too slow. The other night I did 13. Anyway, but as time goes by, the junior registrars will qualify and become senior registrars. The senior registrar year, as you know, is a year of relative rest, but the locums start and the income pattern, the pattern of income begins to change slowly but surely and in a positive way. And before they know it, they are on the specialist register. Hospital practice continues in the public sector as senior registrar, and very soon they are promoted to consultant. In the meantime, private practice has also started. The afternoons are very busy, and so are the nights, but that is not so much the problem because the energy is still there. But yeah, in the midst of all this drama, the years are going by, you know, because you can't stop the years, they move independently. So the signs that the years are advancing will be everywhere. So be watchful, you all obstetricians. Not that it's a bad thing for the years to go by, but the signs will be there around you. And one of the best places to notice these signs, you won't believe it, is actually the theater room, T room, the tea room in the operating theater. What do I mean? In the tea room, you are used to pouring your own tea, you know, and spreading margarine on your own bread. But sooner rather than later, your colleagues will start to offer to do that for you. First of all is the interns. They'll come and say, please sit down, I'll pour your cup of tea for you. And then because the interns are young, you're not very concerned. You think, well, they're young. Even if it was in a domestic setting, probably they'll make the same offer. Then before you know it, it's now the junior registrars. They start offering to pour your tea and to spread the margarine on your bread. And again, you're not too worried because they are youngsters. I hope they're not here. They are not too worried because they are youngsters. But before long, it's actually fellow specialists now telling you to sit down so that they can pour your tea. And now at this stage, you start getting worried. You start saying, I think I'm on the way to the door that leads to the archives. But you will not have seen anything yet by that stage. Because one of the days they'll come close to you and say, please don't bother coming every day, you know. You may sit in the administrative office. Don't worry about calling us. We are going to call you if there's anything. Then you say, hey, I think things are really getting tight. And then one of the days you'll get a phone call. You know, it's one phone call that will confirm that you are now very close to the door to the archives. The message on that phone call is coming on the next slide. stage, then you know, yeah. I'm now finished. So the issue of clinical practice guidelines is almost the same as that timeline, because it also has a timeline to it. Those who were around 2 or 2.5 decades ago will remember that decisions on clinical management of patients used to be based firstly on experience. And whose experience? The experience of the leader of the team. And they were also based on expert opinion. Whose expert opinion? That of the leader of the team. And they were also based on authority. Whose authority? You can fill in the blank space. So, but anyway, gynecologists are usually mild personalities. If a senior registrar tries to offer a different opinion, usually they're just reminded nicely that in this frame we do it this way, not the way that you're suggesting. But I know some other specialties that are quite tough. If a senior registrar tries to do that, they will be shown the door and they will not attend the rest of the round for that day. But, as you know, there's been a lot of changes in medical practice now. Compared to that era, there's lots more information available to practitioners, a lot more evidence. The internet is teeming with databases. You can almost access any journal that you want on the web. During that time, 2 decades ago, I can tell you all we had was the textbook in postgraduate obstetrics and gynae, and a few journal articles, if you could get your hands on them. Now we also have witnessed a growth in the subspecialties, which is again is a good thing. We have to develop on the lines that the rest of the world is developing. Subspecialties are becoming complete and independent disciplines in their own right. There's also the growth of technology. AI is making a lot of contribution now to the way that we practice medicine. And also facilities like virtual reality are now coming on board. So there's no way a single individual can be the custodian of all the knowledge in this present age. I know some colleagues, including myself, from that era, were trying to resist the advent of AI until in one of the meetings, someone just came and nudged one of us and said, "Do you know that your students are actually writing their research proposals using AI these days?" And I said, "Oh, is that so?" "Yeah. Some of the research proposals that you are actually reviewing, they have been written using AI. So if you don't know how to use AI, you're not going to recognize those that have been written using AI. So you better learn now." So there's no room for being left behind. The knowledge landscape has completely changed. One good example of the authority that the leader of the team wielded in days gone by was actually what was called the magnesium sulfate trial, which was done in the mid-90s. This was a multinational trial. It was multi-center, and Salim Gabe, then Harare Hospital, participated in. It was one of the centers. So this trial compared the use of diazepam for eclampsia with magnesium sulfate and phenytoin, and it clearly showed that magnesium sulfate was superior to diazepam for the management of eclampsia. But then what happened? Some team leaders of that era were not willing to make the change, not only locally, but also even internationally. And the result was that, some registrars, and you can guess who the junior registrars during that era were. Yes, I saw some of them here. Dr. Spango. we are the ones who used to discuss in the corridors about the number of cesarean sections done overnight with Dr. Smango and Dr. Machalva. There were very few of us. Yes, so for the calls, you didn't need to look at the duty roster. You just counted 1, 2, 3, third day I'm on. 1, 2, 3, 1, 2, 3, 1, 2, 3. But now you hear some junior registrars complaining about doing too many calls when the department actually has 12 registrars. But anyway, times change. Okay, so What then used to happen was that the juniors were in a dilemma. If you were on call on a day where the leader of the team was for diazepam, then you had to use diazepam despite the evidence of the trial that it just been completed. And if you are going to hand over at 8 o'clock to a leader who doesn't like diazepam, who likes magnesium sulfate, I don't know what you're going to do. Maybe you stop the diazepam and shift to at 8 o'clock in the morning and shift to, I don't know. It was very difficult for the registrars, just to say the least. So, clinical practice guidelines are statements that include recommendations to optimize patient care. You may take note, especially of that word, to optimize. That is to look for the best way of all the ways that will have been researched at that particular time. Which one is the best and which one is the safest? And then these statements are informed by systematic review of evidence and assessment of benefits and risks of alternative options. So that means that evidence has to be there. The research has to be ongoing. The profession has to be active in looking for the best options for treatment and the safest options for treatment. So clinical practice guidelines have got the potential to reduce unwarranted practice variance. They also facilitate translation of research into practice. Sometimes we do research, we get very good findings, but they don't find their way into clinical practice because we don't do systematic reviews to see ways in which we can incorporate them into patient management. And also, clinical practice guidelines have got the potential to improve quality and safety of patient management. Certainly when we're doing these systematic reviews, yes, we're looking for the optimum treatment, but we're also looking for the safest treatment that is available. And the important thing is that they should be developed according to international guidelines. And these international guidelines for the development of clinical practice guidelines emphasize a structured approach. We have to be systematic in whatever we are doing. Like we said, it has to be an evidence-based process, and it has to include multidisciplinary panels so that we reduce bias and we look at the evidence from different points of view. And it also has to have a mechanism for the management of conflicts of interest. We don't want to end up having complaints that so-and-so was involved in that working group, and they're also involved with the company that produces a device that is used for that particular condition. So maybe your guidelines are biased towards that. The process has to have a mechanism to safeguard against such. And we've already mentioned that the process includes conducting systematic reviews to establish an evidence foundation. The good thing about having an evidence foundation is that people cannot argue to say that I don't think that is the correct way of managing such a condition. They can always be told, no, the evidence has been looked at, it's been analyzed, the systematic review has been done, and it's clearly pointing towards the fact that this is the best way to go. And the process has to use diverse working groups so that, again, we optimize on objectivity and to the reduction of bias. One example of lack of standardization, those who might remember, is when oral misoprostol came on board for the induction of labor. We had sometimes up to 4 different regimens being used in the same unit. Some said, we're giving a state dose of 25 mils, and then we give 25 mils 2 hourly. Another team would say, we're giving 50 mils as a state dose, and then we're giving 30 mils 2 hourly. And then even other team would say, we're giving 100 mils, that 25 mils doesn't work. We give 100 mils, then we give 20 mils 2 hourly. And as you can imagine, that creates problems for the juniors, creates problems for the midwives, they get confused. Obstetrics is a specialty where we hand over to each other every 12 to 24 hours. And if we have got so many different regimens for the management of the same thing, then there will be confusion. And also we can't, when there's a lot of variance, we can't monitor patient outcomes well, because it's very important with whatever we're doing to be able to monitor what outcomes we're having for our mothers and for the babies. So it is good that that situation was quickly resolved. People went to the evidence and convinced colleagues that no. The safest regimen is this one, and the one with the best patient outcomes is this one. And everyone agreed, and it is now being standardized. So, as we have mentioned, evidence-based medicine is very important. Actually, it's the backbone of the creation of guidelines. This concept was first mooted by Dr. Gordon Guyat in 1990. He was an internal medicine registrar at McMaster University in the United States. First of all, he had put it forward as scientific medicine. That's how he had put it forward to his colleagues. Said, colleagues, please let's start to practice scientific medicine. But his seniors were not happy. They say, what do you mean? Are you implying that the way we are practicing is not scientific? He could have been correct at that time, but he faced so much resistance, and he went back and he coined the phrase evidence-based medicine. I was just wondering what was going on in his mind when he came up with this suggestion. I think he was probably thinking along the lines that a lot of research is now being done. We are getting a lot of research findings. They are pointing us in maybe a particular direction or this direction or that direction, but we seem to be stuck with the same management models that we've been having maybe for the past 1 decade, or the past 2 decades. And he probably was thinking that it's time that we started taking note of our research findings, translate them into clinical practice, and possibly get the best treatment modalities and potentially the best outcomes for our patients. So guidelines should be based on data, and preferably it should be local data. I know that this has been a bone of contention between colleagues sometimes. This one will say, I use these guidelines for this, I use these guidelines for that. And then the other colleague will argue to say that the data which was used to develop these guidelines did not include any local population. So I'm not following them. So it's important that we have local data, our own research projects going on, especially on day-to-day conditions that we meet every day in gynecology and obstetrics. This can be in the form of clinical trials and other research types that we are familiar with, the observational studies, cohort studies, case control studies. But also of importance is clinical practice data. This is an area where probably we've not been doing very well. The routine maintenance of clinical practice data, data kept in an electronic form, the demographic data for all the patients that we are seeing, the clinical findings, results of investigations, management rendered to them, the outcomes on a daily basis. As the years go by, this data begins to build up, and it can also be very, very useful in formulating clinical practice guidelines, just as useful as sometimes as data that is obtained in clinical trials. I know the subspecialties have started to do this, which is very good, and the advantage of keeping good clinical practice data is that we actually own the data. It's not collaborative. No one will come tomorrow and say, no, this is, we are joint owners of this data, or we're the owners of this data, so we should analyze it this way or that way. This is data that completely belongs to us, and we determine how it should be analyzed and how it should be used. So, but not to say that we should disconnect ourselves from international efforts. For example, the Cochrane collaboration, we can copy their model, the way they do their systematic reviews, the way they use review groups, the way they use international volunteers. We can still be part of that, but it's important to have our own local data. There are some conditions which recommendations have been given in international guidelines, but where with clinical practice you then end up thinking that I don't think this is applicable to our population, because you don't get the outcomes that we expect. So it's good to have our own local data. So because guidelines look for the optimum and the safest treatment. They have got the potential to improve clinical outcomes for our patients, improve the quality of care, improve patient safety, and also help to educate health professionals. As you can imagine, if someone is in training and they are exposed from the word go to what has been shown to be the best practice, then it helps them as they develop their career. And guidelines also help in the assessment of individual practitioners because they act as a framework on which people can be assessed. They also act as a framework on which organizations can be assessed. And they also help patients make informed decisions. The patients can be informed that for this particular condition, usually we follow these guidelines. This can lead to this can lead to that, this can. And they are informed, and then they can actually say which pathway they prefer their healthcare professionals to follow. And in fact, the benefits of clinical practice guidelines has been shown. It has been shown that clinical practice guidelines improve patient outcomes. It's a well-studied area. The results will differ depending on context, but an example is a systematic review which was done by Grimshaw, where they looked at 59 published evaluations involving 55 studies which showed improvements in processes of care. The actual processes of care were shown to be improved by the use of clinical practice guidelines. And of the 11 studies that looked at outcomes, 9 showed that the clinical practice guidelines were bringing better outcomes for the patients compared to the era where there were no guidelines. Cost effectiveness, although cost is not the primary driver for the development of clinical practice guidelines, it has been shown that using clinical practice guidelines can lead to more cost effectiveness. The fact that guidelines can lead to more efficient staff operations. You can imagine if someone is doing something the same way, the same routine every day, they become better and better and better at it. And in that process, time is saved. They improve by improving patient outcomes, we can also reduce costs. By also improving patient safety, we can also reduce costs. And because we're using the same routine every day, we can predict what supplies and sundries we need. And eventually people start looking for ways in which the cost of these sundries can be brought down. And again, because of better patient outcomes, we've got shorter hospital stay. So is that the end? Yes. Thank you very much.
Thank you, Dr. Magwali, and